या फिर मुझे कैसे पता चलेगा कि बच्चे कहाँ पे हैं, मतलब वो व्यू कर रहे हैं या नहीं?
आप वही सेम लिंक देख सकते हैं, आप में तो नेट चल नहीं रहा है,
वही ना।
मैं बता रहा हूँ,
ठीक है।
आपको कुछ नहीं पता चलेगा, आफ्टर क्लास ही पता चलेगा। ऑनलाइन है, यहाँ से मैं देख रहा हूँ।
आप मुझे बता दीजिए कि कब शुरू करना है, मतलब
शुरू कर लीजिए।
कितने लोग ऑनलाइन हैं अभी?
मुझे लगा 20-25 लोग हो चुके हैं।
अच्छा, ठीक है. Good afternoon, everyone. Today we're going to be speaking about laboratory diagnosis of fungal infections. So, first of all, let's talk about the samples which we are receiving in the mycology laboratory. So, we receive all variety of samples. We receive respiratory samples, we receive sterile body fluids, we receive pus, biopsies, urine, blood. We receive serum for serological assays, skin, hair, and nails. So we receive a very wide variety of samples in the mycology laboratory. And the sample collection and transport is very important because the quality of the report and the information we're able to provide will depend on the quality of the sample that is provided to us. So the most common samples we receive are things like respiratory samples, sputum, endotracheal aspirate, BAL, and lung biopsy. Sterile body fluids like CSF, pleural and peritoneal fluid, pericardial fluid, synovial fluid. We receive pus, which we prefer, pus which has been aspirated, so actual liquid pus rather than a swab, because the yield and the sensitivity is better in that case. We also receive tissue biopsies. If a tissue biopsy is being sent to us, we prefer it to be sent to us in normal saline. Please do not send tissue biopsies in formalin, because the formalin will kill the organism and we will not be able to get any culture positivity. We also receive urine samples. So as you can see, all the samples I just mentioned, respiratory, sterile body fluids, pus, tissue, and urine, all these are to be sent to us in sterile screw cap disposable containers. I'll be showing you a picture. Blood for fungal culture. We are presently doing automated fungal culture. Most places are switching to automated fungal culture for blood and for bacteriology also. So the automated blood culture bottles which are available are separate for bacteriology and separate for fungal blood culture. So a fungal blood culture bottle should be directly inoculated with the patient's blood at the bedside. The volume of blood should be around 5 to 10 ml for adults, or at least, and for children around 2 to 5 or 3 to 5 ml. For serum, we generally collect blood in the yellow capped vacutainer, which is also known as the serum separator tube, because it has a gel which allows the serum and the cellular components of the blood to be separated on centrifuging. And skin, hair, and nail samples. This is a very unique sample collection method to mycology. All the other methods you would be using in sending for bacteriology or for any other kind of microbiological investigation as well. Skin, hair, and nail are quite unique in that this sample collection method is only used in mycology. These samples should be preparing in this mycology laboratory. Black paper which is folded and placed into a small envelope and then sealed, and it is sterilized in the hot air oven. And this is used to collect skin, hair, and nail. When I show you a picture, it will be more clear to you. So you can see here, this is a sterile disposable container which is on the left side, which is used for sending all the samples except blood, except skin, hair, and nails, and except for serum. So all the other samples are sent in the sterile disposable container. Blood, as you can see, so urine will be sent in this. If you pour some saline, you can send tissue in this. Sputum, ET, all of those things can be sent in this. Then automated blood culture bottle, as you can see, this is the Bactec bottle which we are using currently, which is for fungal culture. It contains antibacterial drugs in order to prevent growth of bacterial contaminants. So this basically, you can see this bottle has been inoculated and incubated. Normally the bottle contains a clear broth and some resinous beads and an indicator at the bottom. This is a bottle that has been inoculated with blood and incubated, which is why you can see the color has become slightly darker. Then the yellow capped vacutainer, the serum separator tube. As you can see, over here, there is a gel in the serum separator tube, which when you inoculate blood and then centrifuge, the cellular components get separated at the bottom of the gel and the serum is left above the gel, which makes it easier to pipette off the serum for serological assays without it being contaminated by blood RBCs or WBCs. Then this is what I was talking about for skin, hair, and nails. You have a small piece of black paper which is folded. This is one fold which I have opened. Normally it's folded over like this. This is placed inside this envelope and stapled shut, and then it is placed in the hot air oven for sterilization. Now the reason we use a black paper envelope for skin, hair, and nails, there are two reasons. Number one is that on this black colored paper, skin scrapings and nail scrapings, usually they appear white. So if we just place it directly, and they're normally a very small amount of sample, not like say sputum or a tissue bit where it's very easily visible. Skin and nail scrapings can be quite difficult to visualize because they're only a small amount and they're small flecks of a whitish color. So if we put them on a black paper, they will be easily visualized and picked up for processing. This also ensures that the scrapings are kept in a small area and they're not scattered and they don't get wasted. And also the paper is hygroscopic in nature, which means that it absorbs moisture. So this is good for us because we need to absorb moisture in order to inhibit the growth of other kind of commensals from the skin and nails. Normally skin and nails have a lot of commensal flora. You have especially yeasts, which we don't want to have growing in culture. We are interested in dermatophytes or other agents of causing skin and nail infections with like fusarium or like any kind of molds. We're not really interested in growing yeast and especially dermatophytes. So when we're mainly looking for dermatophytes, we don't want yeasts or bacterial commensals to be growing in skin and nails. The problem is that dermatophytes, or indeed many of the other molds like I mentioned, fusarium or aspergillus or neocytilidium, which cause skin and nail infections or hair infections, these are very slow growing. So they take weeks to grow. So if the commensal flora are allowed to overgrow them, then we will never be able to isolate the pathogens in culture. So this paper basically is hygroscopic. It absorbs moisture. So after a skin or a hair or a nail sample is placed on the black paper, usually what is done is skin samples, the skin or nail is scraped directly from the patient's affected area. It's held over the black paper and scraped onto the black paper. And then this is folded and put into the envelope, and then in the mycology laboratory we allow it to dry for a few days. The paper absorbs moisture from the sample and all the bacterial commensals, any yeasts, any kind of environmental contaminants, all of those will die due to the dehydrating effect of the hygroscopic effect of the paper. However, the dermatophytes and other actual pathogens causing skin, hair and nail infections, those contain what are called arthrospores, or they produce what are called arthrospores, which are very resistant to drying. So they will be able to survive in this kind of condition. That's why we use this particular sample collection method, the black paper and inside a sealed envelope for the skin, hair and nail samples. One for easy visualization and collection, and two for the hygroscopic properties of the black paper. So once the laboratory receives the sample, there are certain steps we have to follow in sample processing. First of all, we have to inspect the requisition form. Every sample should come with a requisition form. Samples without a requisition form should not be accepted. And every form should have a complete clinical history for the patient, including any treatment history and any kind of comorbidities, because these are very important in assessing importance of what we get in culture or risk factors for fungal diseases. And it should have a unique identifier for the patient, such as a inpatient number or UHID or any number which uniquely identifies the patient, so that the wrong report does not go to the wrong patient. Ideally speaking, a form should also have a barcode for online entry of reports and for storage of reports and for easy access. But if not a barcode for online entry, at least a correct unique identification number for the patient should be there and a complete history. Without that, the form will not be accepted. Then once we have taken the form and assessed that the name and number on the form is matching the name and number on the sample, that is also very important, that the wrong sample should not have been sent to the wrong form. Then we proceed to gross examination of the sample. So this is important for us because we, number one, assess whether the sample is appropriate or not. So for example, if we receive a swab and the swab is dry, then that's not appropriate. Then we have to reject that sample and request for a repeat sample. Or suppose we receive a sample which is leaking, then we are not going to be able to receive that sample. We have to reject it and ask for a repeat sample to be sent. So we assess the adequate, or if the sample amount is very less, for example in a serum sample, if it's like only some 0.5 ml or something, then the sample is not adequate. Then we have to again request for a repeat sample of adequate amount. So we assess the sample, number one, for is it an appropriate sample, is it in good condition, is it not leaking, is the amount sufficient for us to do whatever tests are required. And also the gross examination of the sample is important because sometimes it helps us to assess how we can best process that sample for getting better results and a better diagnosis. For example, in case zygomycosis. You would know the term of mucormycosis. The current term is zygomycosis because that includes mucormycosis and entomophthalomycosis. Anyway, you'll come to that when you have a class on mucormycosis. So in a case of suspected zygomycosis, we will inspect the sample and look for any areas which are showing dark discoloration or necrosis, and we will selectively dice or cut off those areas and use them for doing microscopy or doing culture, because we have a higher chance of recovering the sample from those areas. Or for example, suppose we are suspecting a diagnosis of systemic candidiasis or oral or esophageal, anything like that. So we look for whitish plaques, and those are the areas we'll use. Or for example, in a respiratory sample like sputum, we look for any areas which are very thick, very mucoid, any areas which are blood-stained, greenish or yellowish discoloration. We pick those areas of the sample and use them for processing, because we'll get a better result in microscopy and culture from them. So the gross examination of the sample is important for assessing the adequacy and selecting the best parts of the sample for processing. Another important thing which we have to take care of in mycology is a big chunk of the fungi which we diagnose, which is also quite a critical fungus to diagnose, is the zygomycosis group of fungi. So that includes your mucormycosis like rhino-orbitocerebral mucormycosis and your entomophthalomycosis. So those are quite critical fungi to diagnose, and we have to be very careful when handling the samples for these when these fungi are suspected, because these fungi are also very fragile. They are aseptate, they are thin-walled. So any kind of very vigorous processing will destroy the fungi, and we won't be able to get a growth in culture. Because in an aseptate hyphae, if the cell wall is disrupted, the cytoplasm just pours out and the fungus is no longer viable and we won't see it in culture. Plus the hyphae themselves get broken and destroyed, so we will not be able to detect them in microscopy. So these samples have to be handled very carefully. This is why history becomes important for us. If a suspected mucormycosis is there or a zygomycosis is there, we have to process the tissue sample very differently than we would normally process a tissue sample. A tissue sample where we're suspecting a septate hyphae, like a hyaline hyphomycosis, something like aspergillus, or a yeast infection or anything like that, we generally grind the tissue in a pestle and mortar, as you can see over here. We grind it so that we can disrupt the tissue and more easily visualize the fungal elements. However, this grinding process will destroy zygomyces. That's why we have to only finely dice small pieces with a blade if we're suspecting zygomycosis in any tissue sample. So this is something we have to keep in mind, read the history and decide whether we want to grind a tissue sample or tease or dice a tissue sample with a needle or a blade. Okay, so we don't grind a tissue sample where zygomycosis is suspected. This is why, as I said, a history on the form is very important for us. So once we have decided how to go about processing the sample, which area, grinding, dicing, whatever we're going to do, then we proceed with the first step, which is direct microscopy. So all samples except blood and serum, for which there is no direct microscopy process, those are directly just processed either by incubation or by performing the appropriate serological test. So every other sample, a gram stain is done. In a gram stain, we're able to look for yeasts primarily. We're able to look for things like nocardia or actinomycetes, which show up as gram-positive branching filaments. Sometimes even filaments or hyphae of molds can be seen in a gram stain, but that is a rare thing. Usually we're looking for yeast, for nocardia, and for actinomycetes in a gram stain. A gram stain also gives us an idea of what kind of cells are present. Is it neutrophilic infiltrate? Is it lymphocytic infiltrate? All those things also can be discerned from a gram stain. Then there are certain other processes of direct microscopy which are done for some samples and not done for others. So gram stain is almost universal except for blood and serum. Then India ink stain or nigrosin stain is done only for CSF. GMSA stain is done only in samples where a histoplasma infection is clinically suspected, as in an intracellular yeast. We'll come to details about histoplasma in your later classes. So especially samples like bone marrow or lymph node biopsy where histoplasma is a highly likely scenario, in those samples we do a GMSA stain. There are other samples where histoplasma be suspected, for example a palatal ulcer or cutaneous lesions, but these two samples are the most common samples where histoplasma is suspected, and so we do a GMSA stain. Then Modified Zeal-Nielsen stain is done only in samples where we clinically suspect nocardia. So for example, respiratory samples, pus from discharging sinuses, granules from discharging sinuses, especially in patients who are on steroids or who are diabetic or immunocompromised in any other way, but steroids is the highest risk factor, and these kinds of samples, respiratory or soft tissue samples like abscess wall, pus, granules from a infected soft tissue lesion, or even from, sometimes it can come from an osteomyelitis. So those samples we will do a modified ZN for nocardia. And the microscopy method which is most useful for us in mycology and which is almost universally done again after gram stain, that is the potassium hydroxide mount. KOH is the short form. So we use 10% potassium hydroxide routinely. For tough to digest samples like skin, hair, nails, we use 20% potassium hydroxide. And for very, very hard samples, for instance, if we get solid bone tissue or a very hard nail tissue, we may even use 40% potassium hydroxide. But the routinely used potassium hydroxide, which we use for most of the samples, is 10% potassium hydroxide. So the role of potassium hydroxide is to digest and dissolve all the extracellular matrix, all the cells, all the tissue, all the proteinaceous material, everything except the fungal elements, to clear it so that we can more easily visualize fungal elements. Otherwise, if the fungal elements are lost in the middle of the cells and the proteinaceous matrix and all of the other extraneous matter, it's very difficult to visualize actual fungal elements. KOH helps to clear all of that. So basically what we do is we take a small amount of KOH on a slide, on a small amount of sample, say a loop full or a few drops of pus, of body fluid or BAL or whatever it is, and we add a drop of 10% potassium hydroxide, mix it and put a cover slip on. You may gently warm the slide in order to facilitate the dissolving process, but it's not necessary to always do that. What is also optional but which also helps a lot in improving the sensitivity of KOH microscopy is to add a drop of calcofluor along with the KOH. Calcofluor is basically a fluorescent dye. The calcofluor binds to the chitin in the fungal cell wall, and then when that slide or that mount is observed under UV light, anywhere where the calcofluor has bound fluoresces bright blue. So it's more easy to visualize the fungal elements. I'll be showing you how different a plain KOH and a KOH calcofluor mount looks. Because the elements will fluoresce against a dark background, it is much easier to pick up and it improves the sensitivity. Even if the fungal load in the sample is low, we have a better chance of picking it up if we use KOH along with calcofluor rather than just plain KOH. Okay, so I'll show you the pestle and mortar which we use for grinding tissue samples. As I discussed, the percentage of KOH can be increased to 20 or even 40%. We are able to demonstrate most of the fungal elements in a KOH mount. For example, hyphae, pseudo-hyphae, yeast cells, all of it can be seen. Whereas in a gram stain, it's a little bit limited. Demonstrating actual hyphae, septate or aseptate hyphae of molds in a gram stain is a little bit difficult. A KOH mount is able to pick up almost all the fungal elements. So this is a plain KOH mount. As you can see here, these are the fungal hyphae. You can see hyphae here, and you can see the septa in the hyphae also over there. I'm pointing out the septa, and these are septate hyphae in a respiratory sample. So you can see septa, the dark cross sections across the fungal element. As you can also see, it's very difficult to separate the fungal hyphae from the background. They're also clear. Okay, and in aseptate hyphae, which are even more fragile, it becomes even more difficult. So because there's no differentiation very clearly seen between fungal elements and background, the sensitivity of the plain KOH mount is less. It's easier to pick it up if there is a high load of fungi as opposed to if there is a low load of fungi. Here you can see what a KOH mount with calcofluor looks like. As you can see, the extraneous material has been cleared by the KOH. The calcofluor has bound to the chitin in the fungal cell wall, and you can very clearly appreciate the septate branching hyphae with the dichotomous pattern which is typical of Aspergillus. This is seen in a BAL sample. You can appreciate the septa, you can appreciate the branching pattern, and it's very easy to make out what is a fungal element and what is and the background is all cleared. One thing which is a drawback of both KOH and KOH calcoflow, but which is much less in a KOH calcoflow mount, is that sometimes artifacts, for example, cotton fibers from a swab or proteinaceous material or any kind of other artifacts, can also sometimes pick up the calcoflow stain or can also resemble fungal hyphae in a plain KOH mount. So it requires some amount of experience in order to differentiate artifacts from actual fungal elements. So the KOH mount should always be viewed by a experienced person who has some experience with telling apart artifacts and fungal hyphae. So a false positive or a false negative is not given. There is one advantage of a plain KOH mount over a calcoflow mount. In a calcoflow mount, the natural pigment of the fungal hyphae is not seen. When it's a hyaline fungus, which is a non-pigmented fungus, then it doesn't matter. But there are certain fungi which are pigmented, a group of fungi called the demetaceous fungi. Their profile is a lot different, the method of treating them is a lot different, their course of infection is a lot different than the hyaline fungi. So it's important to pick up demetaceous fungi as early as possible because it will affect the mode of treatment and the outcome for the patient. Demetaceous fungi usually contain melanin pigment, so they are naturally brown or black in pigment. So as you can see, in a calcoflow mount, everything fluoresces blue. The natural pigment of the fungus cannot be seen. So in a calcoflow mount, the differentiation between hyaline, which is this clear or non-pigmented, and demetaceous, which is this, cannot be demonstrated. This is a KOH mount showing a skin biopsy from a patient of chromoblastomycosis. This contains what are called sclerotic bodies or copper penny bodies, which are thick-walled fungal cells which are brown or black in appearance, and it's very easy to pick them out because of that pigment against the clear background of a KOH mount. This would not be possible in a KOH calcoflow mount. So the one advantage of a KOH mount over KOH calcoflow is picking up demetaceous or pigmented fungi. This is a gram stain showing yeast cells which are budding along with pseudohyphae. This is from a urine sample. This is an India ink mount showing the capsulated cells of Cryptococcus, which is a yeast causing meningitis, especially in immunocompromised patients like HIV positive patients. So as you can see, India ink or nigrosin, which is the substance we use nowadays and which is more common than India ink, it's basically a dark stain and it's what's called a negative stain, as you would have studied in your first classes about staining techniques. A negative stain basically means the organism remains unstained against a stained dark background. So as you can see, this yeast has a polysaccharide capsule around it which does not pick up the India ink or nigrosin stain. So it appears as a bright halo with a yeast with a bright, clear, unstained halo around it against a dark background. This is the typical picture of cryptococcal meningitis. So we do this stain mainly on CSF. This is a modified Ziehl-Neelsen, the Kinune or cold staining method, which is a method which does not use heat, for nocardia. In modified Zn staining, nocardia appear as bright pink, acid-fast, branching bacilli or filaments against a blue non-acid-fast background. So as you can see here, the dots and dashes typical appearance on branching filaments. You can see the branching here and here of nocardia, which is bright pink and acid fast against a blue background in the modified Zn stain. So this is an example of showing how direct microscopy can demonstrate different pathogens. Direct microscopy is very important in diagnosis of fungal infections because fungi are slow growing for the most part. Yeasts like maybe candida may be growing in a few days time, but even that, there is no fungi which will really give you an overnight or immediate growth the way bacteria will. Also, sometimes fungi may not grow in culture at all. For example, zygomycosis, very poor rate of recovery in culture. Or suppose the patient has had a fungi tend to be causing long-standing infection. So if the patient has had some treatment previously, the fungi may not then grow in culture. All this is to say that in mycology or in diagnosis of fungal infections, direct microscopy has a huge role to play, much more so than in most of the other pathogens. So that is why we have so many methods for direct microscopy and why it is so important, because antifungal drugs are never started empirically or usually not. And usually the clinicians will require some report or some confirmation from the laboratory before they'll start an antifungal drug. So rather than waiting days or weeks for a culture report, a positive direct microscopy is immediate, it comes in hours, and it can be a very good guide to start treatment. However, the limitation of direct microscopy is that its sensitivity may not be very good. It all depends on the quality of the sample, on the way the sample is processed. The sensitivity is not like 100%. The sensitivity would be probably in the range of about 60 to 70% for direct microscopy, depending on the technique being used. So just because the direct microscopy is completely negative, it may still come up in culture. However, the limitation of having only in culture and not in microscopy is that can very often be a contaminant. As you know, our environment is full of fungus, spores are everywhere. So even if a sample was left open for a few minutes on the bench top or after collection and spores have fallen into it from the environment, that could give you a growth in culture without a positive microscopy. So either which way, caution should be exercised. Absence of fungal elements in direct microscopy can happen even if there is a fungal infection, if it's a low load or if it's an early stage or a partially treated infection. Positives in culture without a microscopic positive may indicate this is sample contamination rather than an actual pathogen. So in either case, caution should be exercised while interpreting the results. So once we've done our direct microscopy, we proceed to culture. Culture is done on a variety of media. Generally speaking, in mycology, because fungi take so long to appear in culture and we have to incubate the media for weeks or even up to a month in certain samples, the problem with plates is that they are a very large surface area, so the media dries and desiccates very quickly. And because of the large surface area, it's more amenable to contamination and to posing a risk to the person who is handling the sample. So we prefer to put media into tubes rather than plates, which I'll be showing you in a few minutes, because it's better for prolonged incubation, for avoiding contamination, and for avoiding a hazard of infection to the person who's handling every time they open the tube or the plate to check for growth. A tube is a narrow opening, less chance of risk to the person, less chance of contamination to the medium, and the medium won't dry out so quickly. So the most common media we use in mycology is sabouraud dextrose agar. We usually add an antimicrobial like amikacin, gentamicin or chloramphenicol, which helps us to inhibit the growth of bacterial commensals. Cyclohexamide is a antifungal which selectively inhibits certain yeasts. It inhibits some, it doesn't inhibit the others, and also with certain molds. So what happens is whether a fungus grows or doesn't grow in the presence of cyclohexamide, which is also called actidione, that helps us in identification later, because suppose we have two similar looking colonies, one which grows in the presence of actidione, one which doesn't. All of this helps us in later coming to an identification or speciation of the fungus. These drugs, the antibacterials, are all to prevent growth of bacterial contaminants. So sabouraud dextrose agar is used for all samples without exception. The only samples where we use plates rather than tubes is urine and swabs, because those are only incubated for a few days, not more than that. Then we have BHI blood agar tubes. We use these for suspected histoplasmosis, because histoplasmosis is quite fastidious. It doesn't really grow on media which have not been enriched with some source of nutrition. We use a medium called oatmeal agar if we're suspecting dematiaceous or pigmented fungi. Then blood is not inoculated onto agar. Blood is inoculated, as you know, into the blood culture bottle directly. So these are the common media which we're using: SDA, BHI blood, oatmeal, and the blood culture bottle. We also have different temperatures at which we incubate in mycology. So samples are incubated depending on whether we're suspecting molds only, yeasts only, or molds and yeasts both. So in blood and urine, generally speaking, we don't suspect mold infections. It's not impossible, but it's highly uncommon. In these two samples, we usually suspect infections only with yeasts. So we basically incubate these only at 37 degrees Celsius. In skin, hair and nail, again, we don't usually suspect yeast infections because yeasts are normal commensals in skin, hair, and nail. Yes, in rare cases, you can have candida causing a nail infection, but usually speaking, we suspect dermatophytes. There are a certain class of moles in this sample. So we incubate it at 25 degrees Celsius only because moles grow better at 25, yeast grow better at 37. All other samples, because they could get anything, either mold or yeast, and either may be a pathogen. So all other samples we inoculate and incubate 2 sets of tubes, one at 25 degrees Celsius and one at 37 degrees Celsius. So whether it's a mold or a yeast, we'll get growth in either case. So a little bit more about saborodextrose agar, which is the most common medium used in mycological culture. We use what's called the AIIMS modification of saborodextrose agar, which uses less of dextrose and a little more agar, and the pH is also higher. We sterilize it by autoclaving at 121 degrees for 15 minutes, and it's the primary isolation media used for fungi. The reason that it's the primary isolation media used for fungi is not because it's the best medium for fungi. It is not. There have now, it's one of the older mediums. Subsequently, there have been many media which may be better for isolation of fungi. However, a lot of the identification of fungi, particularly moles, is based on their appearance, the appearance of the colony, the texture, the color, the size, the appearance of the colony which is formed. And the appearance of the colony varies based on the media which is used. So a colony, say, of Aspergillus fumigatus will look different on SDA, will look different on blood agar, will look different on BHI. And the classically described appearances of all the fungi are based on their appearance on saborodextrose agar, which was the original medium used for isolating fungi. Therefore, because so much of identification is visual, and all the descriptions which are given in textbooks and guidelines and everything is all based on appearance on SDA. That is why we continue using SDA as the primary medium for isolation. And as I told you, we use cyclohexamide, number one, for identification between different fungi. It also inhibits certain saprophytic fungi, which are environmental contaminants or fungi growing on dead matter. Cyclohexamide's purpose is twofold: inhibition of saprophytic fungi, and helps certain times in differentiating between certain species of yeast. Then chloramphenicol and gentamicin inhibit bacterial contamination. So this is how the broad groups of fungal pathogens appear on SDA. So dermatophytes can appear granular, powdery, velvety. They have a variety of different appearances. But the most common appearance we see in our country, because trichosporon trichophyton is the most common dermatophyte which we isolate. Trichophyton rubrum, Trichophyton mentacus. These are usually white, cottony in appearance. So that's the most common we see, but you can see powdery or yellowish green pigmented, any other kind of growth. Dermatophytes vary widely. Demitaceous fungi will usually be a granular kind of growth, and they'll have a very dark brown or black pigment. And the hyphae will also show pigment in KOH. In dermatophytes, the direct mount of KOH will show very thin hyphae which are septate, and they may also show thick-walled arthrospores. Then yeasts, usually on SDA there will be a cream-colored pasty kind of growth, and in a gram stain, of course, you will see the gram-positive budding yeast cells and pseudohyphae. Zygomycetes, which includes mucorales and entomophthorales, these are cottony or cotton wool kind of appearance, and they grow very abundantly. They fill the tube from top to bottom if they're left to grow long enough. And KOH obviously will show you broad aseptate hyphae. Pheohyphomycosis again is a granular growth which is often pigmented. So as you come to different families of fungi, classes in them in detail, we'll be discussing appearance and identification of them in detail. This is just to give you a broad idea. Okay, so once we get growth in culture, how do we identify it? So if we get growth of a yeast, the first thing we do is to make a gram stain, and then if we're suspecting from the morphology in the gram stain that it looks like it may be candida, Then we'll do a germ tube test. We do a Dalmor method on corn agar. Again, once we come to a detailed class on Candida, you'll be knowing what all this is. We do sugar simulation and fermentation tests. We can use chrome agar or the Malditoff. All these are to identify what the species of Candida is. And we can also do antifungal sensitivity testing by broth microelution or by a Vitek automated method. The other commonly encountered yeast, there are other yeasts in Candida and Cryptococcus, but these two are the most common ones. So for suspected Cryptococcus, we'll be using the urease test. We'll be inoculating on birdseed agar to demonstrate the brown-black colonies of Cryptococcus, and we can even do a Malditoff. If we get a growth of mold, on the other hand, molds are primarily identified visually because the appearance of different molds is very, very different. So, for example, a Candida, whether it's Candida albicans or Candida tropicalis or Candida lugdunensis or Candida any species, it's going to be very difficult to identify them visually. Visually, they're all elliptical yeast cells with budding and pseudohyphae. Therefore, we have all these different tests to identify yeasts. Molds, on the other hand, are visually very different. Each mold looks different from the other. So we primarily identify molds visually by looking at the gross appearance of the colony and by then preparing what's called a lactophenol cotton blue mount, in which we take a small amount of the colony, spread it or tease it on a slide, add a drop of a dye called lactophenol cotton blue, and then visualize under a microscope. We can also use the Malditoff to identify mold. Malditoff, by the way, is matrix assisted laser desorption ionometry time of flight. We can also use molecular techniques like PCR or sequencing of the amplicons from a PCR, but that's less commonly done. Only if we are completely unable to identify a mold visually, which happens but happens rarely, then we'll shift to these methods for identification because they are quite cumbersome and quite time consuming. And we can also do antifungal sensitivity testing for molds, again by the broth microelution method. Vitek is not used, the automated sensitivity testing is not used for molds. So as you can see, this is the white, creamy, pasty kind of growth of yeasts on SDA. And you can see here, this is growth of a zygomyces on SDA. It's a mold. You can see the filament, it's not a yeast-like growth, it's a mold-like growth. You can see the cotton wool appearance, it's starting to grow upwards beyond the medium and fill the tube. So when we want to identify a yeast or mold, here we'll take a small amount of colony with a loop, emulsify it in a drop of normal saline on a slide, spread it out, dry it and make a smear and then gram stain it. With a mold, we use teasing needles or a wire to pick out a small amount of the mold, tease it or spread out the filaments evenly on a glass slide, add a drop of stain in the cover slip and then visualize. So let's talk a little bit about the lactophenol cotton blue wet mount. It's used to mount molds from cultures for microscopy. So it has a few different constituents. The lactic acid basically acts as a preservative and maintains the structure of the fungal elements because the structure and the morphology is very important for us to identify. Phenol kills the fungus, so it's no longer a hazard to whoever is handling that slide. The cotton blue stain is absorbed by fungal structures and it makes them easily visualized and more distinct. And glycerol acts as a hygroscopic agent. So as you can see here, this is a lactophenol cotton blue mount of Aspergillus, showing the conidia, the vesicle and the conidiophore. This is usually visualized under 10x lens for scanning and then under 40x lens for more detailed visualization of structures. We do not view lactophenol cotton blue wet mount under oil immersion. For that matter, any wet mount, even the KOH wet mounts which we do directly on samples, we visualize only under 10x, 20x, 40x. We never visualize under oil. There are, of course, certain other tests which are now being offered in mycology. Earlier, culture was the only method to detect fungal infections. Now, because there is an increased incidence and importance of fungal infections, we're realizing that with the advent of patients coming in with at an early stage of infection or patients coming in partially treated from elsewhere or all of those reasons, fungal culture may not be giving us results quite often. So we need better methods of diagnosis. So we need to look for things like antigen detection. So for example, one of the most common antigen detection tests we do is and one of the oldest ones developed in fungal diagnosis is the cryptococcal capsular polysaccharide antigen test, where basically latex particles are coated with antibody to the cryptococcal antigen, or these antibodies are immobilized on a nitrocellulose strip, like a rapid test. And then we add CSF or serum after an appropriate pre-treatment protocol. And in the latex agglutination test, if the cryptococcal capsular antigen is present, we'll get clumps of white material where they've bound and formed complexes with the latex, which is coated with antibody. In the immunochromatographic method, we get a colored line where the antigen is bound to the immobilized antibodies in the nitrocellulose strip. Another antigen detection test which is becoming very common is the galactomannan assay. This is used to detect aspergillosis. So this is done on serum, on BAL, and now it's recently been standardized for CSF also. This is done in an ELISA format. So we use that to detect the galactomannan antigen of Aspergillus primarily. So we use it in cases of suspected pulmonary or even invasive aspergillosis. Then there's another assay called the beta-D-glucan assay, which is also done in ELISA or CSF. ELISA format, it's done on serum or CSF, and this is mainly used to look for cases of candidiasis, systemic or disseminated or invasive candidiasis. Then we have certain antibody tests. So for example, we have tests that look for immunoglobulins against aspergillus. This is primarily, we do it in patients who are suspecting of an allergic fungal rhinosinusitis or allergic bronchopulmonary aspergillosis, anywhere where there's a possible allergic response to a fungus, especially aspergillus going on. We can collect as serum and look for any of these or all of these antibodies against aspergillus. There are various formats, for example, immunodiffusion, for example, ELISA. This is something which can also be done in diagnosis of fungal infections. Nowadays, molecular methods are also gaining importance. So PCR, of course, can be done. The most common target gene we look for in PCR is the panfungal PCR, which detects the ITS or internal transcribed region, which is the most universal or conserved gene or region of the fungal genome. It's found in almost all fungi, not almost, in every fungi this gene will be present. And then we have other specifics. So we have PCR specific for aspergillus, PCR specific for mucorales, PCR specific for different fungi. But the most common PCR being offered in fungal diagnosis is this, the panfungal PCR. Then we can also do sequencing of either the whole genome of a fungus or of amplicons derived from PCR. There are also roles for other departments in diagnosis of fungal infections. So for example, histopathology plays an important role, because they have a variety of other stains. They can also look for tissue infiltrate or inflammatory response in their thin sections of tissue and in their staining methods. For example, the GMS or Gomori methanamine silver stain is quite often used to look for fungal elements in histopathology, or they may do the mucicarmine stain for cryptococcus. So histopathology also plays an important role, because sometimes they may pick up things that may be missed in mycology. For example, in the case of sporotrichosis or any other kind of fungus producing an inflammatory response called the Splendor-Hopley phenomenon, which you'll be studying later when you come to subcutaneous mycosis. This phenomenon is only visible in a hematoxylin eosin tissue section. And it's very important in picking up certain kinds of fungi. We do not do H&E sections in mycology, so we may not pick it up, but it may be picked up in histopath. So histopathology also plays a role in diagnosis of fungal infections, and definitely radiological investigations play a role. For example, in case of a pulmonary aspergillosis or a pulmonary mucormycosis, there are certain signs that will be seen on a chest X-ray or on an HRCT of the chest. For example, cavitary lesions are more common in mucormycosis pulmonary. Nodular lesions or opacities are more common in aspergillosis. So there is a whole set of signs and visual clues which can be used to identify a possible fungal infection. Even say, for instance, in brain abscesses or in liver abscesses or splenic, there are certain ways in which it can be possible to say this may be a fungal abscess. So radiological investigations are also very important, especially in systemic or deep-seated fungal infections. Okay, so that's all for today's class. The take-home messages for you would be, it's very important in mycology to send us an appropriate sample collected from the right area in the right manner and sent to us in an appropriate way. So if there is any doubt or any question in your mind regarding what would be a good sample to collect for a given condition, it's always better to pick up the phone and call the microbiologists and discuss with them, because you get a much better report if your sample has been collected and transported appropriately. So that's one thing. Sample collection and transport is very important. Please discuss with the microbiologist if you have any doubt whatsoever. The other take-home messages which you need for mycology are: direct microscopy is hugely important because of the slow growing and sometimes not growing fungi which we encounter. So direct microscopy is very important. In many cases, direct microscopy is taken as evidence of fungal infection even if fungi are not grown in culture. So don't, if you get a report of direct microscopy positive, don't delay treatment and don't wait for a culture report which may never come or may come very late. The way you would do, say, in bacteriology, would wait for a culture report to start treating. Don't do that in fungi. If you have any doubt as to how to proceed, which drug, what should be given, you can very well call either the microbiologists or the infectious disease faculty if they are there at the institute where you're working, and discuss it with them that based on this direct microscopy report, what antifungal can we start. Clinical history is very important for us in mycology because of the high presence of environmental contaminants, and because clinical history and what is clinically suspected really changes what kind of processing we do. So for instance, if we're told a patient has a cavitary lesion and is on steroids, we'll think about nocardia. If we're told a patient is diabetic and has an orbital swelling, we'll think about mucus. So history is very important and clinical correlation is very important in mycology. So please fill out the form correctly. Okay? And don't restrict yourself only to traditional culture. For example, very often in pulmonary aspergillosis, if it's at an early stage, we have found cases where culture and microscopy comes repeatedly negative, but galactomannan assay values are extremely high and confirmatory of an invasive pulmonary aspergillosis. So don't restrict yourself to only waiting for a microscopy in culture. Bear in mind that there are others. So for example, in India, in the cryptococcal meningitis, we have had cases where we're seeing no yeast cells at all in microscopy, but the latex agglutination comes positive. Or so basically make sure that you keep in mind that there are other methods of diagnosis and you should avail and use them as well to make your diagnosis for the patient's treatment. Okay, that's all for today. Thank you very much. And if you have any doubts about this class, you can contact me in the mycology laboratory. Thank you.